From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello to our listeners from around the world. I'm Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology Web Editor. Today we are discussing phenoconversion in pure autonomic failure. During this podcast, we'll be referring to pure autonomic failure as PAF at certain times and MSA for multiple systems atrophy. Should we be thinking about pure autonomic failure as a precursor or prodrome to the central alpha synucleinopathies? Here to dive deeper into that question are senior authors Dr. Alessandra Fanciulli and Dr. Eduardo de Pablo-Fernández. Dr. Fanciulli is an associate professor in autonomic neuroscience and director of the Innsbruck Dysautonomia Center at the Department of Neurology of the Medical University of Innsbruck in Austria. Dr. de Pablo-Fernández is a senior clinical fellow at the Center for Preventive Neurology at Queen Mary University of London in the United Kingdom. Dr. Fanciulli and Dr. de Pablo-Fernández, welcome to the podcast.
Hi, Dr. Armand.
Hello, thank you for having me.
Please explain to our listeners, what exactly is the alpha synucleinopathy that is pure autonomic failure?
First, so alpha-synucleinopathy, we understand a group of neurodegenerative disorders characterized at neuropathology by intracellular aggregates of phosphorylated alpha-synuclein, which is involved in this neurodegenerative process. To the alpha-synucleinopathies belong the well-known Parkinson's disease, dementia with Lewy body, multiple system atrophy, and pure autonomic failure. Pure autonomic failure is, by definition, a disease characterized by the presence of neurogenic orthostatic hypotension, so cardiovascular autonomic failure without any secondary cause, developing in an adult person sporadically, so there's no positive family history. And what you don't find clinically is any further sign of central nervous system involvement or peripheral nervous system involvement. So, in a nutshell, pure autonomic failure is by definition an alpha-synucleinopathy limited to the autonomic nervous system.
Making a diagnosis, what's the process of that? Because from what I understand is it may present earlier than the other central alpha synucleinopathies or not, but how do we make a diagnosis of this?
Basically, the diagnostic process can be a long one. So people with pure autonomic failure, usually middle-aged individuals, who at some point develop orthostatic symptoms, or orthostatic dizziness, malaise, sometimes fatigue, or this cognitive slowing up on standing that after the COVID pandemic, we call it brain fog. This is a nice term to describe it. And who do not at first choice go to the neurologist even. They might go to the general practitioner or cardiologist. In this context, it's very important to recognize that the symptoms have an orthostatic character. That means all the symptoms, which are symptoms of end-organ hypoperfusion, develop upon standing, might also lead to a syncope, and ameliorate if this person sits or lay down. So if you have this suspect that an orthostatic hypotension might be present, this is then clarified either with a standing test, so simply measuring heart rate and blood pressure from the supine to the standing position, or in a bit more detailed and precise way with a head-up tilt test examination and additional cardiovascular autonomic reflexes. So if then you pinpoint an orthostatic hypotension, which is neurogenic in origin, so you see that all the cardiovascular autonomic reflexes also have a problem, then the question that clinicians ask themselves is, where does it come from? And so you look for secondary causes. For example, worldwide, the most frequent cause of neurogenic orthostatic hypotension is diabetes, so diabetic autonomic neuropathy. So you exclude these and other secondary causes of autonomic neuropathy. And you look, and this is very nice from neurologists because we have our hands in our job. So you examine the patient and look for additional symptoms of central nervous system involvement or peripheral nervous system involvement. And in PAF, pure autonomic failure, you usually do not find this. What you might find are additional symptoms indicating autonomic impairment, like constipation, bladder disturbances, sweat disturbances. This might accompany the clinical presentation, but other signs are not present. And so is how the diagnosis is done. However, we know now for years that this is a provisional diagnosis because we know better and better that pure autonomic failure might be actually harboring another disease. So the presentation of pure autonomic failure.
So that brings us to the question of phenoconversion. Now, what do we know currently prior to this study that we're going to discuss? What's the landscape of what's known in phenoconversion? Do we know how far along in the disease state does someone present with this phenoconversion? Do we know what characteristics are involved or the percentage of individuals that develop this?
So phenoconversion, first of all, refers to the process where people presenting with pure autonomic failure develop either motor or cognitive symptoms meeting diagnostic criteria for another synucleinopathy, that being either Parkinson's disease, multiple system atrophy, or dementia with Lewy body. That's what has been coined in the literature as phenoconversion. So we know that a proportion of people with pure autonomic failure will develop additional symptoms and will develop additional signs to meet diagnostic criteria for another condition. And that's what prompted our interest in this study. During the last several years, over the last decade or so, there has been interesting studies with retrospective and prospective cohorts from different centers around the world that have followed up these people with pure autonomic failure for many years. And they have noticed that they develop additional symptoms of involvement of other central nervous system structures. And a proportion of them will go on to develop, as I said, motor and cognitive symptoms and meet criteria for other synucleinopathies. So that's what the term phenoconverters has been labeled. And that's what prompted our study to try to a bit of quantify and provide exact figures analyzing the evidence that has been reported and published over the last decade or so.
It's great to answer that question because it definitely informs us at the bedside and chairside what we should be looking for. And especially, as Dr. Fanciulli mentioned, a lot of patients don't come to neurologists. They go to their general practitioners, and it's actually pretty good to have a sense of signaling of this. Excellent. Let's dive into your study.
What prompted our study was to try to summarize the evidence that has been published recently with several prospective and retrospective cohort studies in the literature. So we thought that a good summary and try to understand a bit better the phenoconversion in pure autonomic failure will be useful for clinicians and clinical research. So we review the literature, we perform a systematic review of the literature and set up the inclusion and exclusion criteria basically to analyze studies that reported longitudinal follow-up in people diagnosed with pure autonomic failure without a diagnosis of multiple system atrophy, Parkinson's disease, or dementia with Lewy bodies. And we made two analyses, one to try to come with a quantitative assessment of the pool incidence rate of phenoconversion in people with pure autonomic failure. And the second sort of aim of the analysis was to try to identify mainly clinical predictors, but other additional investigations that can predict phenoconversion and also can predict the disease outcome of people with pure autonomic failure phenoconverting to another disease, which will be useful as well to know if people are converted to Parkinson's disease, dementia with Lewy bodies, or multiple system atrophy.
What were the demographics like?
The studies were 9 cohort studies in total. That included 900 patients from different prospective and retrospective cohort studies that were mainly done in the United States and Europe. And the demographics was that there was like a predominance of male, and there was a median follow-up over 6 years. with our analysis. And it's important to note as well that when they were included at the baseline of the inclusion of the cohort studies, there was already like a pure autonomic failure disease duration of about 5 years.
Now, tell us about what you found.
Basically, the finding of the study was that considering all the people which were investigated in these 9 studies, totaling 900 individuals, were followed up over an average duration of 6 plus minus 2 years, and this was a weighting factor. 30% of individuals with pure autonomic failure, so every third person with pure autonomic failure over 6 years, phenoconverted to what we labeled or what the literature labels as central alpha-synucleinopathies, that is MSA, which is characterized mainly by oligodendroglial alpha-synuclein aggregates, or Parkinson's disease dementia with Lewy bodies, which are so we identify as neuronal alpha-synucleinopathies because there is where primarily alpha-synuclein aggregates are found. And the interesting information that we were able to capture through this systematic review and meta-analysis, which weighted the findings from all previous studies on the sample size and the duration of the follow-up, that we have an incidence rate of phenoconversion of 5% per year. And this is very important because if these people with PAF come to you for a second opinion or they want to know what's happening with me, then it is very important that you can break down this in numbers because numbers can guide the person to know. So what are my odds? What are my chances that I'm actually suffering from something else or that I might develop something else or I might phenoconvert so that I already have something else and I will manifest that this become manifest in myself. 5% out of 100 were shown to phenoconvert to another alpha-synucleinopathy. And an interesting thing was that the phenoconversion was 12% to multiple system atrophy, 11% dementia with Lewy bodies, and 7% Parkinson's disease. So all in all, similar odds MSA versus the neuronal alpha-synucleinopathies. And this is an interesting aspect to consider because in idiopathic REM sleep behavior disorder, which is also a prodromal presentation of alpha-synucleinopathies, we usually observe a higher phenoconversion rates to the neuronal alpha-synucleinopathy, so Parkinson's disease, dementia with Lewy body, rather than MSA, because these have a higher background incidence in the aging population. But this doesn't seem to be the case in PAF, where you have similar phenoconversion rate also to MSA. So likely this autonomic presentation is more frequent in MSA. And basically this breakdown in numbers was the very interesting bit that can also support clinicians in clinical practice to counsel people. And we also went a bit further down the line, looking which were the phenoconversion patterns. And so it was observed that people with MSA phenoconvert earlier during the observational period. And this fits with a more aggressive disease course that we know to characterize MSA rather than Parkinson's disease. And this is again something important in clinical practice because then we know that when we follow up these people over time, every year when these people do not manifest red flags pointing towards MSA is a year earned towards a lower odd that this person might be suffering to this kind of disease or in general from Parkinson's disease.
Right, so presenting earlier rather than later for multiple system atrophy. Now, you had mentioned earlier that these patients in this systemic review meta-analysis, they already had 5 years duration of PAF under their belts. Was there any indication of the severity of disease when phenoconversion occurred? Because I would imagine that when it started at the follow-up that you had, were there varying degrees of whether or not the multiple systems atrophy or the Parkinsonism or the Lewy body dementia was fulminant, approaching end stage, or the degree of the disease? Was that mentioned at all, or? or not?
That's a very interesting question, but I think it's probably there is not much correlation between the severity of the symptoms that people with pure autonomic failure experience with the disease duration, and some of the people with pure autonomic failure develop like adaptive mechanisms to the changes affecting the cardiovascular changes. Unfortunately, data available on autonomic function test or severity of the autonomic symptoms were not available for a deeper meta-analysis. Among the sort of factors that we were able to quantitative analyze in the meta-analysis, the only one that was significant was the presence of the changes in the rate of phenoconversion with follow-up duration, as Dr. Fanciulli mentioned, like people with multiple system atrophy phenoconverting in the first sort of 5 to 6 years of follow-up, while people with pure autonomic failure that subsequently develop symptoms of Parkinson's disease and dementia with Lewy bodies had a more constant rate of phenoconversion. There is a very nice figure, probably like it show it better than my words, in the paper, in the manuscript, that shows this rate, that this changes over time.
Right. It's an excellent figure. And I definitely want our listeners to go ahead and look at that, because this is actually pretty significant. And it's nice if you're having patients that come in and see you and you're going to follow them over time. It's pretty important to see when potentially this could occur, because it could really inform what types of visits you have with your patients, the questions that you ask. And also when we think about therapies, right? We think about how we're tailoring treatments for these patients. Very important to kind of get a lead. We're getting a head start on this. This is pretty excellent. I have a question about the clinical predictors section that you had mentioned in terms of your main outcomes. What clinical signs and symptoms were more likely to be seen in individuals who phenoconverted?
This is a very active area of research indeed right now. What we could find out, and this was a common denominator across all the studies included in our analysis, is that the presence of accompanying hyposmia was pinpointing people that were rather prone or that would rather lately phenoconvert to Parkinson's disease or dementia with Lewy body instead of multiple system atrophy. This is something that we know very well. Hyposmia belongs to the prodromal spectrum of Parkinson's disease. And more in general, and this was helpful to foretell a phenoconversion in both cases, both to multiple system atrophy and Parkinson's disease with dementia or dementia with Lewy body, was the clinical presence of subtle motor signs. So either subtle Parkinsonian signs or subtle cerebellar signs. They have, of course, even a higher diagnostic yield because the differential diagnosis towards MSA. And this was not always polysomnography confirmed, but a history suggested, medical history suggestive of REM sleep behavior disorder was also associated with phenoconversion. And this is quite logical to understand, to have, because REM sleep behavior disorders or subtle motor signs indicate that you already have a neuropathological involvement of the central nervous system, be it at brainstem, olivopontor cerebella, or midbrain level.
The analysis of clinical predictors was a bit more challenging due to the heterogeneity of the different studies, how different symptoms were assessed in different studies, and it was difficult to put that together. And sometimes we had to group some of the symptoms under different categories that prevented a bit more granular and deeper analysis. So one of the elements that unfortunately we couldn't analyze a bit more in depth is the timeline of some of these symptoms, because obviously you would like a clinical predictor that gives you a bit of a window of opportunity to act on. But for example, for subtle motor signs on the main study that reported them and sort of a storyline about the symptoms that show that it was only present within the first or second years ahead of the phenoconversion. So, but that's an element that unfortunately was limited by the data available. And also due to the heterogeneity of the results and the variability on how the different symptoms and clinical predictors were assessed, again, that didn't allow us to make a more granular analysis of some of the clinical predictors, such as, for example, urinary dysfunction, that we still probably believe that are clinically relevant, but we will need further research, future research, with a bit more systematic assessment of some of these clinical factors to make these conclusions.
I think that's a really important point that you made, but nevertheless, in terms of us looking at these clinical signs and just having a lead, we're thinking about hyposmia as being a distinguishing factor for Lewy body dementia and Parkinson's disease. And then we're looking at the subtle motor signs and the REM sleep behavior disorders. Those are important points. And it really is consistent with the natural history of what we've known for these disease entities separately.
Certainly, yes, exactly.
Any closing thoughts on this current study and future directions for this field of neurology?
Well, pure autonomic failure, we now know, is a possible prodromal presentation of central alpha-synucleinopathies and opens a window of opportunity for early disease identification and ideally in the future also early disease modifying intervention targeting the neurobiology of these diseases. The homework we need to do in the next years is to become more and more accurate in identifying people who are at risk of phenoconverting and to which disease. There is a lot of research ongoing. Also, to make us learn to distinguish very well what indicates true neurodegeneration from senescence, so healthy aging, which is also frequent in this patient population.
Dr. Pablo-Fernández, your closing thoughts.
I think in terms of future research needed on this to achieve those goals, I think pure autonomic failure is relatively rare, but as we have discussed, is a very interesting condition. So I think probably for the future, in order to have great numbers, great sample size, international efforts, as we have seen in some of these cohorts, are needed to create studies with systematic assessments where we can evaluate all these features that can predict phenoconversion with a bit more statistical power. So I think international efforts among different specialist centers are required to gather more evidence and make conclusions on this. And the other element as well is obviously not just applicable to pure autonomic failure, but there is a lot of research in terms of biomarkers, imaging biomarkers, molecular biology biomarkers, and so on that are advancing our understanding of the disease and the diagnosis. And that is something that unfortunately we could not include in our quantitative analysis because there was not enough data to make a meta-analysis, and we provided just a brief qualitative analysis in the article about different markers that may be useful. And again, that is something that needs to be tested prospectively in the future in great cohorts of people with pure autonomic failure to find these answers.
Dr. Fanciulli and Dr. Pablo-Fernández, thank you so much for joining us today.
Thank you for your invitation to talk about pure autonomic failure.
Thank you very much. It's been a pleasure. And thank you very much for all the efforts of the team and putting all the data together.
A dream team. Congratulations.
This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.